Good morning my friends and welcome to this video. Currently having my breakfast with some coffee. I'll show you my breakfast now in a moment, what I made, and then what we're gonna do is rewind to what I've been up to over the last couple of days. So in this video, you're gonna see me ordering a takeaway and talking a little bit about how I incorporate takeaways or junk food into my diet without it affecting my goals too much. And then we're also going to go through some questions and you'll have the chance to study with me. So stay tuned and enjoy the video. I'm just cooking up some breakfast and lunch at the moment. We've got some green lentils, get some carbohydrates, get some extra protein, good hit of fiber, some of these red kidney beans, again, nice bolus of both fiber and protein. Smoky lentil and red pepper soups, which I'm gonna add in for sort of like a sauce, I guess you could say. Mix it all together, it's gonna be like mush, and that's kind of how I like a lot of my meals when I'm just, you know, cooking basic meal prep. So got some frozen peas as well, so I'll add those in just for some greens, and that will do me for a nice nutrient dense, high protein, high fiber meal that will take me no more than 5 minutes to cook and 5 minutes to eat. Patty got me this for my birthday. I think it's hilarious. It's just like the most millennial thing ever. Like, I need my morning coffee. And if you're here for cooking tips, that's not me. I'm not that guy. I'm a man of simplicity when it comes to my meals. These are very much function focused. I know that looks disgusting, but it's not a big deal once you stir it in. Normally I wouldn't just fling a soup like that into my meals here, but I'm trying to empty out the cupboards, use the things that haven't been used, so this will do the job. Again, just using up things that are in the cupboard. This is just like some leftover taco seasoning that's there, so I'm just gonna add it in. Small bit of chili powder, garlic, turmeric. Now it's starting to get much warmer, smokier smell, a little bit of sweetness, and that'll do the job. Quick 10-second break to remind you that we currently have coaching spaces available. I am finishing up my medical exams, and once they're done, I'm going to be taking on far more coaching clients. So if you'd like to work with me or another member of the Triage coaching team, get in touch now by emailing info@triagemethod.com or clicking the link below. Now let's get back to the video. It's Saturday night and I'm having myself a glass of red wine. I'm also going to order a takeaway. I do, in fact, enjoy myself. I haven't actually eaten that much today. And on that note, with regards to getting a takeaway, I think what a lot of people try to do is they try to make it super healthy and they'll get something that they kind of enjoy, but it doesn't really scratch the itch. I get what I want, so I get what I'm genuinely going to enjoy. If it puts me over my calories a little bit and I don't have a major goal or a deadline, that's fine, that's not a big deal. And if I know I'm going to be having a takeaway, I'll just eat a little bit less during the day. And I don't try to do these things like, oh, I'm going to get lettuce buns for my burger. And that's not to say that you shouldn't, because I appreciate that if your maintenance calories are like 1500 versus 2500 to 3000, far more difficult to fit in maybe what you want from the chipper. Like, it's going to be hard to get a double cheeseburger and the milkshake and garlic cheese chips. Hard to do that. So I appreciate we're all a little bit different in that sense. My favorite chips to get are actually curry and stuffing. At home in Kerry in Killarney, I'd always get curry and stuffing chips. Absolutely amazing. Okay, don't knock it till you try it. The sweetness, oh, it's handsome. Well, I'm putting the feet up and chilling out for a while. My next exam is on Tuesday. That's obstetrics and gynecology. And it's a multiple choice style exam. So as they say, practice as you play. So I've got, you know, various subscriptions that I use, Past Medicine and Past Test most notably, for practice questions. So I'll do practice obstetrics and gynecology questions now for the next half an hour or so until that comes. And legend burger, a battered sausage, full chipper mode, and garlic cheese chips, and a Fanta lemon to top it off. So the thing with chipper, it never looks aesthetic, does it? But I'm gonna enjoy this. Hello my friends and welcome. It's Monday morning and you're joining me doing a bit of study. Tomorrow at 9 AM I've got an obstetrics and gynecology exam.
Question 1. A 27-year-old woman presents to her general practitioner complaining of vaginal soreness, itchiness, and discharge. On examination, the doctor can observe an inflamed vulva and some white, lumpy, and thick vaginal discharge. The cervix looks normal and there is discomfort on bimanual examination. She has a past medical history of asthma, is well controlled with salbutamol, and type 1 diabetes, and has no known allergies. Given the most likely diagnosis, what's the most appropriate next step?
That they don't just want you to know the diagnosis, so it's not just like, here are the hints, what's the diagnosis? It's, what's the next step in management, or what's the most appropriate step? So this lady most likely has vaginal thrush, okay, so candidiasis. They've given that description of soreness, itchiness, discharge, and then that white, lumpy, and thick vaginal discharge. Given what they've said, I'd be leaning towards just prescribe oral fluconazole as a single oral dose, and that's correct, okay? So what I'll often do then is, when I'm doing questions like this and I'm studying, I have a page here in Evernote, so this is where I'm taking notes at the moment. Obs and Gynae final med exam prep, okay? And if there's a question I get wrong, or there's a topic I don't know, I'll make some notes on that topic, alright? So at the moment, I think I have an idea as to what's going on there, so I won't make notes.
Caroline's a 33-year-old mother of 2 who's unsure if she's completed her family. She presents to you with an 8-month history of amenorrhea. She had been having a normal menstrual cycle for 30 months following the birth of her last child. She's never taken any oral contraception or hormonal contraception or had surgery of any kind. Her abdominal and gynecological examinations are both normal. There's no clinical sign of hyperandrogenism, and you confirm that she is not pregnant. Okay, so this lady has lost her period for 8 months. She had been having a normal cycle for 30 months following the birth of her last child. So it's not just that this is since her last child. She's not on any contraception, right? So they give you some tests then. Her follicle stimulating hormone is decreased, her luteinizing hormone is decreased, estradiol is decreased, prolactin is normal, TSH is normal, and T4 is normal. After a 10-day progestin challenge, she does not have a withdrawal bleed. She's got amenorrhea, right? She had normal cycles for 30 months following the birth of her last child. And one of the conditions here, Sheehan syndrome, is a condition that often happens during pregnancy or maybe just in the postpartum period, where you get pituitary necrosis, okay? But we see here that she had normal cycles for 30 months, so I'm thinking, right, that's probably lower in my differential here now. PCOS potentially is another option, but they're saying, right, her abdominal and gynecological examinations are normal and there's no signs of hyperandrogenism. So again, that's kind of pointing away from that. Hypothalamic dysfunction is something is potentially the case here, because what we see is FSH and LH are both low, so they're both your pituitary hormones, and they're stimulated by gonadotropin releasing hormone, which is released from the hypothalamus. So if you had hypothalamic dysfunction, that would lead to defects down the chain then in FSH, LH, and of course estradiol. Then we've got premature ovarian failure, and that's an option in that we do have signs of ovarian failure with low estradiol, but the problem with that is that we also have low FSH and low LH, and if you just had premature ovarian failure, we'd expect the FSH and the LH to be higher, okay? And then pituitary adenoma, which would be an option here, because we do see signs of the pituitary hormones being decreased, but then we see normal prolactin, normal TSH, and normal T4. So the other pituitary hormones seem to be in a normal place, so it's kind of pointing away from that. So I think all of that together probably points to some form of hypothalamic dysfunction. I'm not very confident, but correct. Okay, so that's correct. So you can see the way that the reasoning works there. So it's not just a case of I see some hints, I know the diagnosis. You have to work through the process of exclusion. So secondary amenorrhea, low-level gonadotropins indicate hypothalamic causes. Right? I'm glad I got that right, because after talking through all that, I didn't want to get it wrong. Okay, that's fine. So 19-year-old female starts microgynon 30. I don't know if that's how you pronounce it, but combined oral contraceptive pill, so it's an estrogen and progestin on day 8 of her cycle. How long will it take before it can be relied upon as a method of contraception? Not actually sure about this now, to be honest. So day 8, so it's the week before ovulation would be expected to take place. That's the point at which fertility is going to be greatest. So they're asking, would it be immediate, 2 days, 5 days, 7 days, or until the first day of the next period? It's going to be a little bit of guessing here, I think. Okay, we got it right. So I said 7 days. Didn't think it was instantaneous, but I wasn't very confident in that now, to be honest. But 7 days is correct. Okay. So if any of you are listening here and you want to learn about when your contraception is effective, there you go, 7 days. You're working in general practice. A 53-year-old female presents with 2 months of her vaginal bleeding. She passed through the menopause at 49 years old. Her body mass index is 34 kilograms per meter square, and she drinks 18 units of alcohol a week. She's only had one sexual partner her whole life. She has no pain during sex or postcoital bleeding. Which diagnosis is most likely? Okay, this is a 53-year-old female, 2 months of PV bleeding. She's gone through the menopause, so it's postmenopausal bleeding. she's obese, she drinks 18 units of alcohol, one sexual partner. Okay, so what they're getting at there is, right, it's unlikely this is a sexually transmitted infection. No pain during sex, or postcoital bleeding. Which diagnosis is most likely? So generally what they're getting at here is that there's some sort of endometrial hypoplastic or cancer related change. Okay, so she's postmenopausal, she's obese, she's got some risk factors, so probably leaning towards endometrial hyperplasia. Yes, correct. So endometrial hyperplasia may present with intermenstrual bleeding, postmenopausal bleeding, menorrhagia, and irregular bleeding. All right. We've gotten 4 in a row. Okay, so we've stayed until I get one wrong. A 35-year-old woman presents concerned because she's not in a period in 6 months. She also reports feeling increasingly fatigued and having worsening mood swings. She last had sex more than 3 weeks ago and uses condoms regularly. She has 2 children and does not wish to have further children in the future. Her last circulating result was 2 years ago and it was unremarkable. Her observations and abdominal examination of both normal blood tests demonstrated raised FSH, the follicle stimulating hormone level, normal thyroid function, prolactin results, and negative serum human chorionic gonadotrophin HCG result. What should be the next investigation? So what we're doing here is we're investigating secondary amenorrhea. She's 35 years old, she hasn't had a period in 6 months, and she has been feeling increasingly fatigued with worsening mood swings, so sort of vague symptoms. So the raised FSH is important there, along with the serum HCG. So they put in the serum HCG to tell you, right, this lady's not pregnant. Then they put in the raised FSH level to tell you, okay, there's something going on that's impacting her pituitary hormone levels. And in this case, that generally points to just a raised FSH in a lady with amenorrhea, secondary amenorrhea, premature ovarian insufficiency. Okay, so we've got the raised FSH, but the ovaries aren't responding with ovarian hormones. Okay, so raised FSH would point me towards premature ovarian insufficiency. Now, to diagnose premature ovarian insufficiency, you need to have 2 different readings of FSH. So one of the options in the answer here is repeat FSH level in 4 to 6 weeks. So that is something you do. But the question is, what should be the next investigation? This is always what makes it difficult because you're not entirely sure of, is there something else I should be doing before that? I don't really know if a pelvic ultrasound is necessary. I know repeat FSH level in 4 to 6 weeks is correct. I'll just go with that because I don't know about the ultrasound. Okay, correct, right. So repeat the FSH in 4 to 6 weeks and the diagnosis correct, premature ovarian insufficiency. Wonderful. Thank you for your help. A 23-year-old woman comes to the GP with a 3-day history of vaginal itching and thick, non-odorous white discharge. She previously complained of the same symptoms 4 months ago but has no other medical history. She's married and sexually active with her husband. Her period is irregular following a 28-day cycle. Vaginal pH testing reveals a value of 4.3. All additional investigation should be performed before treatment. Okay. So I think this is very similar to our question we had earlier, to be honest. This sounds like vaginal thrush, candidiasis, and the options then are various different tests you could do, and then none needed is one option. The diagnosis is clinical, and in this case I'm saying the diagnosis is clinical, no more investigations needed, and that is correct. Wonderful. 24-year-old sexually active woman presents to GP complaining of itching and in the genital region combined or accompanied by white discharge. Vulvar erythema is seen on examination as well as a white vaginal discharge. Vaginal pH 4.25. What is the likely cause of this woman's presentation? Okay, so this is again very similar. So Candida albicans is what we're going for here. Vaginal candidiasis. Okay, wonderful. We're on a roll. They shouldn't keep giving us these. A 28-year-old pregnant woman wishes to receive measles, mumps, and rubella and a MMR vaccination. She's never received any MMR vaccination and is worried that her baby may be infected. As a result, she's currently 12 weeks pregnant and there are no sick contacts around her. Which of the following is the correct response in this scenario? So they're basically getting to the idea of, should this be given during pregnancy? I think you wait till after. Right, that's correct, okay. So MMR vaccine should not be administered to women known to be pregnant or attempting to become pregnant to avoid becoming pregnant for 28 days after the receipt of an MMR vaccine. Okay, so you normally give it after. Right, fine. 23-year-old female patient presents to her general practitioner with thick white vaginal discharge. So again, we're doing the same thing here, guys. Vaginal candidiasis are the experts. I'm just going to skip to the end. So best management option, we know the diagnosis. And the best is oral fluconazole. Wonderful, correct, fair play. 36-year-old woman comes into your GP clinic 3 months after giving birth. She reports ongoing palpitations, weight loss 5 kg since delivery, and some tremors in her hands. She reports her baby's doing well and she's bottom feeding. Okay. So weight loss, tremors, palpitations, kind of points to hyperthyroidism, so excess of thyroid hormones. Thyroid function test here, she has a TSH level of 3.5, which I think is low, and a T4 of 20, which is high. Okay. I think we can give carbimazole. I'm not sure. These are medication. This is an anti-thyroid medication. Propranolol is an option here, which controls the symptoms of hyperthyroidism. I'm going to go carbimazole. I'm not entirely sure. Oh, we were wrong, right. So patient is presented with symptoms of postpartum thyroiditis. Okay, this is an autoimmune condition which presents as the body transitions back from the immunosuppressed state of pregnancy to normal immunity. Present for 1 year following delivery, most frequently occurs 3 to 4 months postpartum. hyperthyroid phase should be treated with beta blockers and not anti-thyroid drugs. Okay, very good, perfect. So we got one wrong, so I'm gonna leave you guys there because otherwise you'll be here all day. Hope you enjoyed that. You're experts on vaginal candidiasis anyway.